Hello, welcome to Medical Vacation. So in this video we'll be talking through the various airway devices that I use clinically. So as an outline, we'll go through a little bit about airway management as a whole, and then we'll move on and talk about our Nasopharyngeal Airway or our NPA, our Oropharyngeal Airway or our OPA, also known as Guedel, our Supraglottic airway devices or our SADs, and then our endotracheal tube as well, which is what we actually use for intubation. Now, as the name suggests, we can kind of almost guess where these devices are placed. So for example, with the nasopharyngeal airway, it's inserted in the nose, it ends up in the pharynx. Our oropharyngeal airway is inserted in the oral cavity and it approaches the pharynx as well. Our supraglottic airway device is inserted through the oral cavity and it just ends up just above the epiglottis. And then we've also got our endotracheal tube, which finds itself within the trachea. Alright, so when we look at someone's airways, we want to make sure that there's no obstruction. So we can firstly see if there's any stridor that's audible, any gurgling noises, whether they're snoring, whether they have a quiet voice, a hoarse voice, they're coughing. And if they're talking in full sentences, that's a really good sign, because usually to be able to talk in full sentences, we can't have an obstruction going on. And then just be aware though that, you know, when patients have a complete obstruction, just in that imminent stage, they might be completely silent. You might just see them panicking. So if we're looking at the patient as well, also checking for cyanosis, checking if there's any obvious foreign body, any tongue bites, tongue swelling, edema, any blood, any vomit in their mouth. And then it's also really important when we're assessing someone's airways to kind of see whether there's any imminent risk of airway compromise, if not now then later on. So for example, if their GCS is really low, if they are, you know, having an anaphylactic attack, anaphylaxis, if they have angioedema, if they are in status epilepticus, things like that, where we know that they might be okay now, but they may not be okay later. I guess once we've done that initial airway assessment, there are little things that we can do before we even consider an airway device. So we can try some airway maneuvers. So we can tilt the patient's head back, lift up their chin, thrust their jaw up. And why do we do this? So that we can manually really open up the airway. So as you can see in this image here, when the person's lying down, very often you might get the back of the tongue just obstructing the airway there, and so that's why we lift up the chin, tilt the head back, and as you can see, that really clears up that airway so that they can get oxygen down to their lungs. The other thing that we do early on is suctioning anything that's visibly obstructing the patient's airways. So any vomit, any blood, we'll remove that. And then whilst we're getting all the airway equipment sorted and everything like that, if the patient's desaturating, we can always give them supplemental oxygen as well. Alright, so once we've done that initial assessment, we've done a few basic things for the airways and they're still not looking very good, we can move on to some adjuncts. And the first lot that we'll talk about are the adjuncts that help with the upper airway and that help it from being obstructed. So we've got two there. We've got a nasopharyngeal airway or NPA, and we have an oropharyngeal airway or OPA, also known as the Guedel airway. And then later on we'll talk about more advanced airway techniques. So we've got our supraglottic devices, which are our classic laryngeal mask airway, ProSeal, LMA, also our eye gels. And then the last thing we'll talk about is our endotracheal tube or ETT. Right, okay, so the first one that we'll talk about in terms of our devices is our nasopharyngeal airway or NPA. So this device will help bypass any airway obstruction at the level of the nose, nasopharynx, base of the tongue. Also helps prevent the tongue from occluding the pharynx. We can use this for patients who are conscious and who have a high GCS above 8, unlike the other ones that we'll talk later down the track. And that's because our nasopharyngeal airway doesn't really touch the pharyngeal muscles, it doesn't elicit the gag reflex, hence it's more comfortable for the patient because they're not choking. And so it's something that we tend to also use early on, and then if it doesn't suffice, we move down to other airway devices. The other thing that this one can be useful for, apart from patients who have a strong gag reflex, is for patients who can't open their mouth very wide, who maybe have a large tongue. So going through the nose is the benefit there. Things to note with this one though is we can't use it for patients who have fractures or trauma at the base of their skull, of their facial bones, their midface, their nasopharynx, the roof of their mouth. Just because we would be prodding and poking into an area that is sensitive. If we're blasting oxygen into it as well, we can also cause subcutaneous emphysema, and then we could potentially go intracranially as well if there's a fracture just at the base of the skull. The other thing to think about is these devices can cause epistaxis because you're shoving it in someone's nose. So if they are coagulopathic, if they're on an anticoagulant, bleeding disorder, just being careful. Also being careful with nasal polyps, recent nasal surgery as well for obvious reasons. We know that there are different sizes of nasopharyngeal airways and that it's important to choose the right size. So how we measure is we go from the patient's nose all the way to their tragus or the lobe of their ear. If that measures out and it fits within that distance, that's a nice size to choose. And how we insert it in is we spray a little bit of lidocaine on it just to help the patient feel more comfortable. We'll lubricate it, and then we'll insert it in. Now, sometimes people like to just go vertically in. Some people like to twist it up by 180 degrees. But essentially, once it's in, we'll secure it with a safety pin, and that's that. Alright, so the next one that we'll talk about is our Oropharyngeal Airway or Guedel Airway. And this airway really helps to prevent the tongue from occluding the epiglottis. Like we mentioned before, so with these airways we want to make sure that the patient has a GCS under 8 or at least unconscious or sedated, otherwise it would be very uncomfortable and they'd be choking. So there are, again, many sizes that are available for the Guedel airway, and it's important that we choose the right size. So how we measure that is we go from the corner of the mouth and we go all the way to the earlobe. And then once we choose the right size, we tend to put the concave aspect of the device upwards. We then insert it into the patient and then we rotate it by 180 degrees when we're beyond the hard palate or the tongue. So once we're around there, we turn it around by 180 degrees just so it sits on the patient's tongue. We know that the tip is to slip just below the patient's lips and it lands and rests on the patient's teeth. Okay. We don't want to push down very hard. That can cause bleeding. Now, the thing is, the Guedel airway isn't meant to be like a definitive airway. Patients aren't meant to be on it for hours and hours and hours long. If someone's unconscious for that long, we tend to start to think about, okay, well maybe we need to actually intubate them, and this is just a way of bridging through and maintaining their airways until we get to intubation. So if they're tolerating it for a very long time, we're thinking about the next steps to take. Alright, so then we talk about the supraglottic airway devices, and these devices, there's a few different ones. The classic device is called a classic laryngeal mask airway, as the name suggests, and this is what it looks like. So essentially we shove it down the patient's throat. That sounds really crude, but essentially we shove it in. There's an inflatable cuff, so we'll put a syringe and inflate it to keep it in place. These days there are some newer devices, so we have our eye gel, so this is what it looks like. So the eye gels, again, we insert it into patient's throat, and it's meant to kind of naturally form and mold to the patient's anatomy, which can be quite useful. And then we have the ProSeal MA as well, which we don't really see in Australia all that much, but it is used in certain areas. I guess knowing that eye gel, there's different sizes. depending on the patient's weight. There's a small, medium and large size as well. And I guess the other thing to note, like we mentioned before, but just recapping, is that patient should be under a GCS of 8 or unconscious. We tend to use this a lot, say outside of hospitals, say for example if an ambulance is bringing the patient in and the paramedics don't intubate, and a Guedel and an NPA is not sufficient, so then they might choose to put in a supraglottic airway just on the way to the hospital. And the other thing is, intubation or using an ETT can be very difficult at times. And so if you have a failed intubation, that's another indication of when you might use a supraglottic airway device. And then at times, certain surgeries are quite short. Patients don't need to be intubated. And so they can go by with a supraglottic airway device. So this is almost kind of like in between the devices that we've mentioned before, our nasopharyngeal, oropharyngeal, and our endotracheal tube. Alright, so then on to the endotracheal tube, and just as a preface, we won't go into this in very much detail. There is actually a lot to intubation. It's a very complicated technique, lots of considerations, lots of different drugs are involved as well in the procedure and process. And so we can create a different video separately just going through it by itself. But I guess just as an overview, so this tube, like the other tubes, patient has to be, low GCS, otherwise sedated. When we insert the tube, it goes all the way into the trachea. As we can see here, this is what the device looks like. There's an inflatable cuff towards the end. And so essentially we deflate the cuff and then we insert it in. It can be quite a tricky procedure, which may require quite a few attempts, and it's also quite a lengthy procedure compared to the other ways, the other airway devices. And so essentially we insert it in and then we inflate the cuff and it stays within the trachea. One benefit of the endotracheal tube is that it can help reduce the risk of aspiration, so food going from the stomach entering into the lungs. It's not 100% fail-proof, but it does help, and it is a more, I guess, reliable source of providing oxygen and ventilation to the patient because it's right in the trachea. You've got access to the lungs and it can help directly with gas exchange. So I guess the other thing to note is that we mentioned there's a lot of medications that go with the procedure, so the patients have to be on medication to help with pain, to sedate them, to paralyze their pharyngeal muscles as well. So it's a very involved process, very complicated process. Alright, so that's kind of going through the different devices. We can just quickly go through what we've talked about. So we gave a little bit of background about airway management. We talked about the nasopharyngeal airway, our oropharyngeal airway, also known as our Guedel, our supraglottic airway device, and then a little bit about the endotracheal tube as well at the end. We hope you found this video useful, and we hope you go and spread your own light bulb moments in medicine to others as well. Thank you for listening.